Good afternoon, everyone. Welcome to today's Healthcare Improvement Foundation webinar entitled Delaware Valley Patient Safety and Quality Award 2019 Lessons Learned. My name is Liz Owens, and I'm a project manager at the Healthcare Improvement Foundation, serving on the clinical improvement team, and I am pleased to be joined by my colleagues Cassidy Tarullo, Pam Braun, and Valentina Moreno. Today's webinar will be 1 hour in length, where we will hear insights from our 2019 top 3 winners about their award-winning initiatives. We will plan to hold all questions for each presenter until the Q&A session at the end. Before we get started, just note that all participants are muted by default. We are recording today's webinar, and all registrants will receive an email from Cassidy with the recording link, a PDF of today's slides, and a link to the evaluation. We ask that you please take a moment to complete this evaluation, as your feedback is essential to PPC programming and our continued improvement of this program. We can go to the next slide, please. Just a quick overview of the Safety Award program. HCIF has hosted this program since 2002. Currently, we're in our 18th year. We're pleased to announce that in 2019, we had 36 entries to this award program from PPC contributing organizations. This year, we did have to adjust the recognition of our winners, and we're pleased to share that in place of an annual in-person conference, where the top 10 winners typically share through presentations and poster boards, we decided to complete individual recordings with the top 10 winners and their teams, just to give a more kind of in-depth sharing opportunity about their initiatives and how one can replicate them at your own organization. So just a big thank you to the award-winning teams for being nimble and pivoting with us. And we encourage you to check them out on HCIF Safety Award page. You'll see up on the screen, that's our website page. And if we can maybe throw that link in the chat, you can take a look at some of those initiatives. Please feel free to look at the videos as well as the initiatives themselves. And just for those that are unfamiliar with the Safety Award program, it's a program that recognizes hospitals, health systems, and other providers for their innovative contributions in advancing patient care. And it ultimately is about promoting best practices in patient safety and quality throughout the region. Lastly, it is funded by the Partnership for Patient Care, otherwise known as PPC. And PPC is a collaboration between Independence Blue Cross and the Philadelphia Region's hospitals, and it's managed by us, by HCIF. As we begin to hear from our 2019 top 3 winners today, we'd just like to remind attendees what the criteria for award entries is. So it consists of, the initiatives are being judged on it being replicable, innovative, current, collaborative, and really having that senior leadership commitment and support. And we can go to the next slide. While you do listen to today's speakers, we would just like for you to think about a few things. We'd like you to pull out some highlights that are important for you to share with your own organization. See if you can identify some of the key factors that made these 3 projects successful. And then to think about how these projects could be replicated at your own organization, should they be a good fit. So we'll hear today first from Lan Nguyen of Mainline Health, and then from Dr. Joseph D'Orazio from Temple University Hospital. And then we're actually going to hear from Dr. Jaffe's colleague, Dimitri. He is with Thomas Jefferson University Hospital. So now I just would like to remind today's speakers to make sure you take a moment to introduce yourself, to please just mention your role in this initiative you're sharing about, as well as at your own organization. And at this time, I will hand it off to you, Lan, so we can go to the next slide. Yeah. Lan?
Thank you very much, Liz. So hello everyone, and hope you had a good Friday morning so far. My name is Lan Nguyen, Process Improvement Engineer at Mainline Health System. I have been working with ERAS team since the beginning of the project, July of 2018. It's very honored to represent my team presenting Enhanced Recovery After Surgery, called ERAS work at Mainline Health System. This presentation is a summary of our ERAS work journey. why our organization started ERAS, key factors made our work successful, how we expanded the ERAS protocols to many surgical services, how you can replicate ERAS work at your organization. Next slide, please. Based on clinical evidence, the lack of standardized approach leads to variations in the care and outcomes of surgical patients. This process inconsistency contributes to preventable complications and avoidable costs. Next slide, please. You can reduce complications and avoid costs through process improvement based on evidence-based, standardized care, and improved outcomes. With high volume of surgical cases at Manlike Health, we chose ERAS pathway to promote the recovery of patients undergoing surgery throughout their entire perioperative journey. ERAS is an evidence-based care pathway which has been found to result in improved outcomes for surgical patients post-op. The pilots for the ERAS pathway of colorectal surgery patients not only limited in hospital opioid use, but also reduced post-discharge opioid prescriptions. Next slide, please. Our goals are reduce physiologic and psychological stress caused by surgery, achieve early return of bowel function, early ambulation, improve pain management, decrease post-op length of stay, reduce incidence of complications, and reduce cost. Next slide, please. How we achieve the goals. We chose Lean Six Sigma DMAIC framework for our project. We established the collaborative group led by the System Director of Surgical Services, Chief of Surgeons, Surgeons and Anesthesia Champions, Nurse Manager of Surgical Nursing Units, Nurse Educators, Clinical Informatics, Data Analysts, Physical Therapists, Respiratory Therapists, Process Improvement Engineer, and Project Manager. We use ERAS protocol only for elective cases, and the cases were booked as ERAS in advance. Patient education about ERAS started from the surgeon offices. Patients were scheduled as ERAS received the ERAS education checklist, which advised patients step by step how to prepare for the surgery. ERAS patients were instructed to stop smoking and drinking alcohol several weeks before the surgery. All ERAS patients, except type 1 diabetic patients, were advised to drink the pre-surgery drink. You can choose ClearFast or Ensure pre-surgery, and the patient will drink the pre-surgery drink at least 2 hours before arrival to the hospital. The purpose to reduce insulin resistance and tissue glycosylation, improve post-op glucose control, and enhance return of gut function. Anesthesia provides goal-directed fluid therapy, which plays an important role in ERAS pathway. In colorectal ERAS, the ClearSight system is used to help reduce variations in fluid administration and guide optimal volume management in patients at risk of developing complications. We created ERAS Care Bundle and includes the appropriate timing and stewardship of prophylactic antibiotics, skin preparations for surgery, removal of the operative wound dressing after 48 hours in conjunction with smoking cessation, adequate glycemic control, and promotion of post-op pneumothemia during recovery, expedite flow length and ventilation weaning. Next slide, please. Our ERAS journey at Manlike Health. We formed the team and prepare for piloting the ERAS protocol for colorectal surgical service in July and August of 2018. We piloted colorectal ERAS in December 2018, and later the other set was built on Epic. We monitored the progress and expanded ERAS protocols to cardiac, thoracic, urology, bariatrics, gyn-onc, and OB surgical services. Our next surgical service apply ERAS pathway is urogyn and plastic services. Total 967 surgical cases were scheduled at ERAS until March 2020. We have a scorecard for each surgical service to monitor the outcomes and identify the opportunities for improvement. Next slide, please. The measures are average length of stay, average PACU pain score, pre-op analgesics administered, day of surgery ambulation, readmissions, percentage antibiotics administration 60 minutes re-incision. We have monthly ERAS meeting where the representatives of each surgical service line attend. We share the scorecard and discuss any issues and propose the plan for improvement. This is the ERAS work at MedLife Health, and thank you for your listening. Next, the second prize winner presentation, Opioid Stewardship in an Opioid Epidemic Work at Temple Health. I will hand off the presentation to Dr. D'Orazio. Thank you.
Okay, thanks for having me today. My name is Dr. Joseph D'Orazio. I'm an emergency physician, medical toxicologist, and addiction medicine specialist here at Temple University Hospital. And I'll be discussing our opioid stewardship program and how Temple is trying to make a difference in the opioid epidemic here in Philadelphia. Next slide. So I probably don't need to give too much introduction to who we are here at Temple. I think, imagine most of you know about us, but our main campus is located here in North Philadelphia on Broad Street. We have multiple other sites, including Temple University Hospital Episcopal Campus, which is located near the Kensington section of Philadelphia, Jeans and Fox Chase campuses, which are also in Fox Chase. We care for patients in some of the most underprivileged zip codes in the country, suffer from an extraordinarily high rate of violence and therefore substance use. It's quite a daunting task nonetheless. Next slide. And if you haven't heard, Pennsylvania as a whole is disproportionately affected by the drug overdose crisis in the United States. And by the latest 2020 CDC data, PA ranks number 3 in overall number of deaths attributed to overdose, and number 4 when it's broken down per capita. And for Pennsylvania, 71% of our counties are above the national average in overdose per capita. Philadelphia having the highest death rate in the entire state. And this number continues to rise. Next slide. And so this is a graph to show you where the overdose deaths are occurring in Philadelphia. And you can see that the star is Temple University Hospital, our main campus. You can see that 5 of the top zip codes, 6 zip codes where overdoses are occurring are just around the area of Temple University Hospital. And so really from my experience of working in other places in Philadelphia, I can clearly say that Temple is the epicenter of the overdose crisis here in Philadelphia. And fentanyl is really the most frequent drug related to overdose deaths. Next slide. With the background set of the problem that we face, here are the goals that have been set forth by Temple Health System in response to the opioid epidemic. Number 1, to achieve an overall reduction in opioid prescribing across all practices. This current epidemic started as a prescription drug problem, and it has evolved far from that, but we need to do our job as good stewards to prevent future cases by preventing overprescribing. Reduce the burden of opioid use disorder by intervening directly with individuals who struggle with substance use disorders. We engage with our community through a hub and spoke model to bolster care in the area. Strengthen addiction assessments through standardization. enhance physician prescribing practices in inpatient and ambulatory settings, including adding lower default values for opioids, update prescriber education through professional development, and fostering employee wellness with improvement to our employee assistance programs. Next slide. This is a schematic of the substance abuse task force that was created for the Temple Health System. It comprised of 6 different subcommittees, including the Trust Program, our Cease Addiction Program, which is an innovative low barrier access addiction medicine mobile unit, Social Determinants of Health Subcommittee, Physician Prescribing Practice Subcommittee, an Education and Research Committee, and a Wellness Group. This multidisciplinary, interdepartmental, institution-wide task force was led by Dr. Sue Freeman, who at the time was the president and CEO of Temple Center for Population Health. This is quite an endeavor, and it goes to show you that the opioid epidemic really has a wide-ranging effect in our health system. And this program is really built on the idea that everyone has a role in this epidemic, and we all need to be playing our part in managing it. And so today we're going to be concentrating on the Trust Clinic program and physician prescribing subcommittees, because I believe those were the most impactful ones. Next slide. So the Trust Clinic was started in 2017 as an on-campus, office-based opioid treatment program. And as we didn't have any other option for patients prior to that on campus, and was started by myself and Dr. David Ogorick from the Department of Family and Community Medicine here at Temple. The clinic was grant funded in 2018 through a Pennsylvania Coordinated Medication Assisted Treatment Program, or PACMAT grant, which is funded by a 21st Century Cures Act. The PACMAT grant provides funding to set up a hub and spoke style program to engage with various community-based practices. You can see right there on the right. We're able to support and expand 10 different spokes with the first round and have continued to expand beyond that. At the hub, which is the Trust Clinic, we started as a 2-provider program offering 3 half-day sessions and have expanded to 5 days a week with 6 providers. And we use various departments, including internal medicine, family medicine, and myself in emergency medicine. We offer a variety of services, including linkage to housing, food, transportation, support groups, and help with medications. And as part of the grant, we were able to increase the number of ex-waiver physicians within the health system to prescribe buprenorphine. And that included a lot of primary care providers, hospitalists, and emergency physicians. Next slide. This is a summary of interventions we enacted to improve our best practices as it pertains to physician prescribing. We utilized education and EMR standardization to achieve this goal. A few items to highlight are an integrated prescription drug monitoring program right in the EMR, and that allowed the prescribers ease of use of the PDMP. We added lower default values for opioids, improved our multimodal pain regimen sets, and standardized our screening protocols pre-op. Next slide. And as a product of these efforts, we saw a continued reduction in our total morphine milligram equivalent, or MME, in our ambulatory setting. You can see here that we had 54% reduction in total MMEs prescribed in those offices through the health system. And this was not patient volume adjusted, so actually it may be more dramatic because our volume has gone up during those periods of times. And on the right is our 2020 data. And this is a little difficult to interpret at this time, especially with the hospital being shut down for essentially 3 months due to COVID. But we continue to monitor our prescribing habits. Next slide. This is a breakdown of how our health system has been performing by specialty. We saw our largest drop in total MMEs prescribed in family medicine, internal medicine, and our pain management clinic. And this is mostly attributable to a decrease in chronic opioid prescribing. Next slide. As you can see here on the graph on the left, we saw a consistent decline in total MMEs administered in the hospital. This decline, we believe, comes from a combination of projects that were implemented, including education about risk of long-term dependence to opioids, multimodal therapy, and our own ERAS program too. The graph on the right is newer data from our EMR, and we're just beginning to access that. And it's a little difficult again because of COVID, but I imagine we will hit a nadir at some point, and we'll need to make sure the pendulum is not swinging to the other side, but we continue to monitor that behavior. Next slide. There has been a sustained increase in regional anesthesia, including peripheral nerve blocks, and I think this is a huge factor how we're able to decrease some of our opioid prescribing. The ability to anesthetize an entire region provides excellent pain control, which facilitates a decreased need for intra and post-op opioids, which then allows for early mobilization, fewer complications, and many other beneficial effects. Next slide. So we really saw a dramatic change in our institution's ability to manage opioid use disorder with the emergence of the Trust Clinic, which is a lot to do with the PACMAC grant that we received. As the hub for this project, the Trust Clinic has allowed us to offer an on-campus option for patients, which is really a game changer. With the help from the grant, we were able to expand our capacity immensely. We're able to offer hot meals for patients with food insecurity, as many of our patients were unsheltered and without income when they first engaged with our program. We now had staff dedicated to linking patients with long-term housing, food banks, cell phones, and medication. When we started this, the previous wait times were about 2 months to see a provider, and with the addition of multiple providers, we were able to fit in patients just within 2 days. And then it's sort of become the norm for physicians to bridge patients with medication until they're able to get into our office. We've been able to link with numerous community services and make this a community approach. As the hub, these offices were able to lean on us for the services they were maybe weren't able to provide in their office. And so it made it a really a whole perspective. Next slide. Here's a list of some of the community and health center spokes that we engaged with. They're all mostly in the North Philadelphia area. We've built meaningful relationships with these offices, and really it's become part of the fabric of how we deliver care. Next slide. We continue to improve our quality of care and reassess how we're doing, including increasing our capacity for patients, continue to partner with local public health partners, improving access to warm handoff initiatives, bolstering pathways to medication use disorder, caring for pregnant women, and many other initiatives. Next slide. So in conclusion, I imagine you're sitting here wondering how your institutions, or maybe other institutions, could reproduce this initiative since we had such great results. I think probably the one thing that sticks out for me is that this was one of the rare instances that all of the leaders' agendas were aligned. Across the network, we all played a part in decreasing the risk of long-term dependence to opioids and improving our access to substance use disorder care. And so it really took a focused effort from our institutional leadership, along with coordination with state and local agencies, including our public health department, to achieve these outcomes. Thank you for your time. And I will pass it off to Jefferson with Dr. Demetrius.
Hello, can you hear me?
Yep, we can hear you.
Perfect. So good afternoon. It's great to be here on behalf of my team at Thomas Jefferson University. My name is Dimitri Papanagnou. I'm an associate professor and vice chair for education in the Department of Emergency Medicine. Also, in the med school, I'm the associate dean for faculty development. My background is in medical simulation, education, specifically in situ simulation. I also have a great interest in gamification and serious great games, and apply these vehicles to augment learners for teams in the clinical learning environment. So it appears that my team shares these interests of mine. So when we thought about leveraging medical education to address our patient safety problem at Jeff, looking at the popular escape room was a natural decision. More on that in a few. But first, let me allow me to describe our problem at Jefferson. Next slide, please. I think most of us would agree that our residents, whether locally, regionally, and nationally, could be more engaged in institutional patient safety processes. In 2015, during our ACGME clinical learning environment review, the CLEAR review, we found that 2/3 of our residents self-reported knowing about our institution's patient safety priorities. However, the overlap between the areas identified by residents, faculty, and leadership was in fact poor. This was concerning. 90% of residents stated that they had received formal training in patient safety, but interviews with them suggested that less than 10% recognized the value in event reporting. Specifically, with regards to event reporting, if you look at the data, between 2014 and 2018, only 2% of total reports were from house staff, from residents. And only 44 of our incoming interns in 2018, so that's 41% of total respondents, had previously received training in event reporting. A mere 5% had previously entered an event report. So like many institutions, we have previously invested much of our efforts on team training. Significant energy and money was invested in training clinical leadership and team steps, but unfortunately, when you really look at this picture here, this hasn't really filtered down to residents as we had initially expected. And in our 2018 House Staff Report of the Patient Safety Culture Survey, 82% of our residents endorsed a favorable response for teamwork within units, so that's within units, but only 61% submitted a favorable response for teamwork across units, reflecting challenges when cross-specialty groups must work together. Next slide, please. It's tough combating the hidden curriculum. It's really tough when we remind ourselves how important patient safety is. It's so important that we're now doing this on the first day of residency in a major way. Our patient safety escape room represents the intersection of innovation in medical education, patient safety, and quality. So some of you might be thinking, what's an escape room? Most of us know, but for those of us who do not, it's when you pay someone a sum of money, like 30 bucks, to lock you in a room with 9 other people for an hour where you have to solve tough, complex puzzles to get out. And it's not so straightforward. They're typically riddled with distractions. For some, it's a nightmare, but for a select few, it's the ultimate game plan for a Friday night. For more information, you can scan the QR code on the bottom right-hand side of my slide here. I'll warn you that QR codes were an essential component of our escape room, so consider this a primer. So we designed a patient safety escape room that aimed to achieve the following goals: to improve residents' ability to identify patient safety priorities, as well as common hazards that relate to each of these priorities at Jefferson, to reinforce students' role in hazard mitigation within the CLE, the clinical learning environment, to assure residents that they can locate and use the event reporting system, and of course, to build teamwork across training programs at Jeff. Next slide, please. Just like the traditional commercial escape room, our educational innovation represents an immersive, problem-solving experience where interns from multiple specialties must work together to do several things: to identify and mitigate common patient safety hazards in a simulated clinical space. And I'll describe what this simulated clinical space actually is. To actually enter an event report using our actual event reporting system. And then to apply teamwork skills to address patient safety issues. Now, from an educational perspective, which is my specialty, it leverages several educational frameworks, including active learning, gamification, and adult learning theory, allowing us to target higher levels of learning in our interns. And that's what we want to do. That's what we want to do. We want to target higher levels of learning. Next slide, please. So here's an overview of the schedule. After all incoming residents were divided into teams of 8 to 10, we briefly oriented them to the activity. You'll be surprised to find out how many never participated in a commercial escape room. I guess that says something about us. They then participated in 2 successive escape rooms, each 20 minutes in duration. The first escape room that they participated in was followed by a facilitated debriefing by one of our simulation champions. The focus of this debriefing was on observed teamwork skills using the JTOG. The JTOG stands for the Jefferson Team Observation Guide, a validated, behaviorally anchored tool to gauge teamwork performance that we developed years ago. So this debriefing took about 10 minutes. Now, after this, interns were given a second chance to participate in an escape room. Note the opportunity here for deliberate practice. This too was 20 minutes in duration. All of this took place at our sim center. So 4 simultaneous simulations, 4 simultaneous patient safety escape room simulations were taking place. Following their second simulation, all residents participated in a large group debriefing where we took a deep dive into safety priorities and tried to connect these experiences and apply these experiences to the real clinical learning environment. And this debriefing took 20 minutes. Next slide, please. So here's an image of the instructions our resident teams were provided with. Residents were given a quick intro to the goals of the exercise. Now, QR codes were essential to this exercise. So you're the resident, you're about to enter a hospital room where your simulated patient is suffering from several significant harms. There will be an observer in your room. Your job is to identify as many patient safety hazards as you can. Please write down the hazards on your worksheet. If you're able, please correct the hazards. You may move items around to do this. To escape, you must enter an event in CS STARS, Jefferson's Event Reporting System. The problem is you don't have the login information or the patient's medical record. As you identify clues, you'll be given this information as they are revealed. When you see a QR code in the room, scan it with your phone. Not every hazard will have a QR code, so keep your eyes peeled. You have only 20 minutes, so work together. Next slide. And the team that identifies the most hazards and escapes in time wins. Cheesy? Yes. Engaging? Yes. Next slide, please. After residents were given a quick intro to the goals of the exercise, they were then immersed in the escape room. Here, you'll look at a very, very fancy, very sophisticated schematic of what the room looked like at our sim center. You can see that all the hazards are labeled for your review. All bed rails being down for a fall risk patient, safety socks not being on the feet, falls bracelet not on the patient, isolation cart with no gowns, sink being out of order in an enteric room with precautions, bed too high, allergy bracelet not on the patient, ampicillin running with an ampicillin allergy documented in the chart, Foley in the patient with an order for it being DC'd. Yeah, you get the idea. Priority learning topics were marked with a QR code. Safety education and a clue were revealed upon scanning. So if you'd like, please scan away. There's a QR code in the top right-hand corner. So they were learning as they were going along. So for example, here, if you click the top right QR code, you'll be able to see what the learners experienced in real time. Keep that up for a few moments for you to scan. Next slide. Yeah, so priority learning topics were marked within the room by a QR code. And you can move on to the next slide. So here are our learners doing these. So here are our learners. There's a simulated patient and they are engaging with the materials to take a look and identify those patient safety hazards. Next slide, please. Here is another aerial shot of our residents. So while these simulations were going on, we were in a room from the control deck watching behaviors. You will notice an observer in each room who's using the JTOG to capture behaviors. Next slide, please. And these are the patient safety priorities that, so if you're concerned about patient safety, so this is what we wanted them to do. We wanted them to speak up, and these were deliberate behaviors that we had in the JTOG to ensure that they were speaking up. We wanted to ensure that those residents in the room that were quiet, that were noting those patient safety hazards, were escalating those patient safety hazards to the team leader. As you can imagine, this space was very small. So as residents came in, some gravitated towards one section of the room with some hazards being detected, and others went to the patient, others went to the medical record. The idea was that some clues were visible to learners, and we wanted them to speak up so the entire team could see what they were doing. Next slide, please. After, this is where we had a chance to debrief. We debriefed in the room. We went over the JTOG. It was a very fun activity. The residents enjoyed it, as we will touch upon the data. Next slide, please. Here again is another depiction of our facilitators during the debriefing. Again, the first debriefing was 10 minutes. And this is where we focused on teamwork and communication skills, priming them to move on to the next simulation, the next escape room, where they were able to deliberately practice the teamwork skills that were discussed during the debriefing. Next slide, please. And of course, all teams that won entered the all teams essentially entered the master debriefing room, and akin to what you'd expect to see in a real commercial escape room, we did have props just to create that level of engagement, to diffuse that level of anxiety that some may have had. Applying the principles of simulation, we really wanted to untether the affective domain as they sort of entered the large group debriefing. So some levity here was able to do that. And as all the teams completed, we gathered in a large group to go over what went well, what could have been improved, and how we can make connections with the real clinical learning environment. Next slide, please. And here's our team of gamers. That's Rebecca right there in the blue skirt. I'm sorry she cannot be here for you, but that's me in the back there making trouble. Next slide, please. So how can you build an escape room, a patient safety escape room? Some lessons learned. You first want to convene a working group with experts in patient safety and medical education. The patient safety priorities must be finite. They must be agreed upon by the working group, and they have to be easy to communicate to your learners. You want to make sure that you have topic experts identified who can really identify the most prevalent and the most high-risk safety hazards for inclusion in these simulations. This is how we were able to engage stakeholders like the Office for Patient Safety and the Chief Medical Officer and the Chief Quality Officer and the Chief Nursing Officer. Letting them know that we were working on Jefferson priorities further supported our initiative. In addition, you want to pilot your patient safety escape room prior to implementation. It's amazing how many mistakes, how many errors you can find in your design. And you definitely want to be interprofessional. You want to include interprofessional facilitators who can incorporate their own work experience in debriefing sessions. We had nursing, we had medicine, we had EM, IM, surgery, we had pharmacy. Next slide, please. Here is an infographic that we created for our participants. It highlights all of our safety priorities. You'll notice that each one has a QR code that provides reading material for each one. This way they had some homework to do. Each participant that participated in the patient safety escape room received a laminated infographic after the exercise. Next slide, please. So the question all of you are asking is, did this experience work? Well, to guide our evaluation, we use the Kirkpatrick framework, which includes evaluation across 4 levels. Level 1, did the learners enjoy the training? Did they enjoy the education? Level 2, did learning transfer occur? Did they learn something? Were they able to demonstrate that knowledge? Level 3, did the intervention change behavior? Were they able to apply what they learned in a subsequent event and apply what they had previously learned? And the last level, level 4, the most important level, did the training influence performance in real life? As with most interventions, we strive for the highest level, but it isn't always easy. For those of you that have designed educational programs, you're probably thinking about some sort of pre-post survey. Did they like it? Did they answer the multiple choice questions around knowledge correctly? That's great. But if you really want to see the lasting impact of your programming, you want to make sure that they're able to change their behavior and that they're able to apply these behaviors where they work. Next slide, please. Did the patient safety escape room work? We did this for 2 consecutive years. We weren't able to do this, sadly, in 2020 because of COVID, but we are in the process of putting something together virtually. More to come. But in 2018 and 2019, we immersed 267 learners in this experience. This represents 30% of our total house staff at Jefferson and included 92% of all eligible interns. And guess what? All residents escaped in the 20-minute time limit. Next slide, please. Diving a bit more into the data, the vast majority of participants across all specialties felt that the activity was relevant to their practice. Comparing pre and post-test escape room confidence levels, you can see here the pre-activity confidence in identifying patient safety hazards improved from 6 to 8 following the activity. Next slide, please. Our teams were able to identify at least one hazard in each of the 9 priority areas at a pretty high rate. Just to recap here, our hazards are depicted: venous thromboembolism prevention, skin integrity, infection control, medication safety, electronic health record documentation, hand hygiene, procedure safety, fall prevention, and of course, speaking up. You can see the rate at which these were reported by teams in CS stars in that actual program. We had dummy accounts created by IS&T that allowed us to make this as high fidelity as possible. So as you can see here, all rates of reporting are pretty high. This gives them the best way to practice this skill, which in previous years, believe it or not, was done through a simple PowerPoint orientation by the Office for Patient Safety during intern orientation. Think about the contrast in engagement. And if you look at best practices in medical education, this is an experience that should be linked with higher retention in this subset of adult learners, at least we hope. Next slide, please. Depicted here are the teamwork scores as measured by the Jefferson Teamwork Observation Guide, the JTOG. We have highlighted here highest and lowest scoring domains for specific teamwork skills. With regards to capturing scores, observers in the escape room completed the JTOG. We also had reviewers watching these in the control room, as you saw from the previous photo. Then, interns had the opportunity to complete the JTOG as they reflected on their team's performance during the debriefing. So we have evaluations from observers, but we also have completed JTOGs from the learners themselves. We collected these scores and aggregated them. Interestingly, JTOG scores were significantly higher when assessed by the team than by an observer. There was also a non-significant trend towards improvement in teamwork skills during the second time through the simulation, suggesting that the patient safety escape room is a valuable opportunity for debriefing on teamwork skills and allowing learners to immediately apply and deliberately practice these skills. We're now in the process of longitudinally capturing the number of CS star reports entered in our system, hoping that this behavior will be captured in real clinical practice, linking to higher levels of Kirkpatrick's assessment. Next slide, please. So my team and I appreciate this recognition and support. This represents one of the few educational interventions we found to address training of event reporting. There really is nothing like this out there, something that is so important yet so infrequently taught and included in formal curriculum. And that's what we're trying to do here. We're trying to take what is in the hidden curriculum and bringing it to light as formal. I'd be excited to answer any questions. For specific details of this innovation, we recently published this on AAMC's MEDED portal. We want to make sure that this is applicable to other institutions. The cookbook for how to do this with our cases and the scripts are there for you to download and use and adapt. I'd be delighted to share the link with you so you can adopt this at your respective institution. Thank you so much.
Great, thank you. I'm gonna move on. So I wanna begin by congratulating our presenters for their remarkable work and award-winning initiatives Thank you to our third place winners at Mainline Health, represented by Dr. Lan, our second place winners at Temple, represented by Dr. D'Orazio, and our first place winners at Jefferson, represented by Dr. Dimitri. So now we'll be moving on into some discussion. And as mentioned earlier, all lines are on mute. So if you have any questions, please raise your hand and we will unmute you or type your questions into the chat box. So kicking off the Q&A, we asked if there were questions during registration, and there were some questions for Jefferson regarding the scalability of the intervention. I know this was for residents, so the question was if this is applicable to nurses, rad tech, PT, OT, for the patient safety escape room.
Great question. Earlier, I highlighted that our team consisted of an interprofessional constituency. So we had representatives from nursing and pharmacy that were involved. We are in the nascent stages of developing this for our interprofessional colleagues. Unfortunately, COVID threw a wrench in that plan. There was talk about opening the 2020 patient safety escape room to all professions for orientation processes. This would not only augment training for other parties, but would really make that clinical team a little bit more authentic. Definitely possible, definitely congruence with the objectives. If you remember the objectives that I started out with, these are patient safety priorities, and the patient safety priorities of the clinical environment belong to all of us. So definitely applicable, definitely something that we're cognizant of, definitely something that we're working on. And we hope that when this goes live again, we will include our interprofessional colleagues. Great question.
Great. So can I open it up to any other questions?
Valentina, this is Pam Braun. Just also a shout out to the speakers. Really very impressive programs. Thank you for sharing all of the details around those programs today. My question for all of you is really what's next? How will you build upon the work that you've accomplished? And so, for instance, Lon at Mainline Health System, will you be rolling out ERAS protocols to other procedures? Would be one question. For Dr. D'Orazio at Temple, what's the next focus for the Substance Abuse Task Force? And for Dr. Dimitri at Jefferson, just curious if you're going to be applying the gamification, which is really a cool program, if you can apply that to maybe other learning opportunities. So love to hear from each of you.
I think I can start first about the ERAS program at Mainline Health. So we've been in the ERAS pathway journey for more than a year, and that's how we optimize our pathway like to the best care for our patients. We standardize our protocol for all surgical services because when we started and beginning is some variations among surgical services, and the feedback that we need to have some specific ERAS pathway for each surgical service, and that causing the variations in the care. And we standardize the process for pre-op, PACU doses of medications, and we basically, how to say, we come to the point that everyone, when we say ERAS in Mainline Health, people know that the protocol very well, and we going to launch to other surgical services, a general surgery, urogyn, and plastic. So basically, it's a journey to overcome all the barriers in communications, agreements with honor surgeons about the medication and anesthesia team support to move forward for ERAS to hopefully we can use ERAS pathway for all surgical services at Mainline Health in the next year. Yeah. Thank you.
This is Joe D'Orazio from Temple. We have lots of things that are sort of like in the process of creating or sort of expanding. and it sort of seems to always be a moving target, but clearly, increasing our addiction medicine presence at our institution on multiple levels, having 7-day-a-week access to consultation, optimizing our warm handoff, especially from the emergency department, increasing our capacity. We've expanded our capacity, a large amount, but we're trying to increase our capacity even more by sort of decentralizing our care from the hub to include other offices, and sort of normalizing the care for patients with substance use disorder. And so like every primary care physician in our institution can manage this problem. Also increasing our levels of care, because actually at this time we only offer a office-based opioid treatment program. And so maybe adding other additional levels of care. And then from the prescriber standpoint, an opioid dashboard for all providers to sort of do a self-assessment of how we stand compared to our colleagues when it comes to opioid prescribing.
I can also answer that question. I think earlier when I presented that Kirkpatrick model, we really want to make sure that this training intervention does something to actual clinical performance in an unsupervised environment. So we are working with IT, and we are working with our Office for Patient Safety to collect data to see how many events are reported by our house staff officers. Correlation is definitely not causation, but it would be really interesting to sort of cross-sectionally see if there is an uptick in the number of event reports in our system. Also, leveraging kind of the hub and spoke model, we sort of think about this education as the bolus and drip model. So if you can consider this patient safety escape room at the time of intern orientation, where everyone's together and they have this super immersive exercise, that essentially is the bolus. And the idea in the drip is to ensure that this happens across residency programs. So we have worked with program directors to ensure that there are patient safety initiatives taking place. We do have GME-wide sessions where a lot of this content is brought up, but there needs to be some retention. There needs to be some repetition to ensure retention. We don't want this to decay. I think a lot of individuals that think about education and training get really excited about applying these novel, innovative approaches, and it's kind of a one and done. And I think there needs to be some intentionality, a longitudinal approach, a vertically integrated approach where this can be infused as a kind of hub and spoke model in training. But right now we're just trying to see if there's any uptick and see what the trends show. We're optimistic and are excited to report those findings, and then really work on the ground level with residency programs to ensure that these practices are continued to be reminded.
Are there any other questions for the presenters today?
Valentina, this is Liz. I'm just curious about for Jefferson about the kind of what you mentioned about the virtual. If you could just expand on kind of where you're going with that due to the pandemic and everything.
Sure. Much like the classroom, our simulation center is off limits. It's really difficult to get a large crowd organized within the lens of education. So we are starting to put together some pilot testing of what this experience would be delivered on Zoom. In the Department of Emergency Medicine, for our graduate medical education program, our assistant program director developed a virtual escape room that is facilitated on Zoom that again leverages QR codes and puzzles and the breakout groups with reconvening in a larger group. So it's possible. Zoom has proven to be a very powerful tool, and we'll see what happens. But I think if we can tweak it over the course of the 2020-2021 year, it is possible that we can replicate this experience for our incoming House staff officers. And if not in the large group as we originally intended and originally designed, there is a way that we could deploy this training to the individual programs so that they can integrate this into their own specialty specific onboarding. So for incoming surgery residents, this can be embedded in their onboarding, and perhaps they can build in other priorities that they want in their escape room. So yes, it's possible. We're working on it. We're piloting it right now in smaller programs. Zoom is a powerful tool. We just need to determine whether or not this will be as large of a program as it was now, or if we need to break it up and do it in chunks. But we definitely don't want this to go away, because this was definitely a highlight of onboarding our interns, and it was exciting to do. So we want to continue that.
Thank you for those responses. And I think, Valentina, I'm not seeing anything in the chat, and I'm not seeing any raised hands. So perhaps we'll wrap up today's webinar. So I'll hand it over to you, Valentina.
Okay, great. So I just wanted to say thank you again for joining us today. HCIF is pleased to announce that this year's call for entries will be open for submissions in October of 2020. And we look forward to seeing your organizations and teams submit the innovative patient safety and quality improvement work that you've been doing over the past year. I would also like to ask if the presenters are willing and able, if you can stay on the line for a quick debrief.